So maybe we can start. Actually, the purpose of this meeting is to give you an idea how the oral exam will go on, mainly to assure you that it will be in a friendly, how to say, manner. And mainly we will be trying to do it as we normally do reporting in our offices. Oh, here, Zara. Hello, Zara. Hello, Zara. Good morning. Zara is not showing herself. Okay, so the preparation course of this exam, as I said, is to familiarize you with the oral exam. And actually what I want to say that this is not an EBNM exam. Oh, hi, Zara. Do you hear me? No, she is very concentrated on something.
Maybe.
Hello.
Okay, so this is not an ENM exam. This is UEMS EBNM exam, and don't mix those two things. The other thing is what I wanted to tell you that actually UEMS was created a lot of years ago, and it has more than 60 medical disciplines throughout various bodies and structures. And the most important ones are in the 41 specialist sections who represent independently recognized specialties. Actually, this is the full list which I found on the website. And as you see, nuclear medicine is here among those all specialties. And the nuclear medicine section was established in 1990. Actually, the UMS EBNM board was established in 1993, and the main objective is to guarantee the highest standard in the field of nuclear medicine. We have our committee among the other three committees. So we have fellowship committee, we have accreditation of nuclear medicine departments, we have accreditation of meetings through CMEs, and we have education and syllabus committee, and above all of us is executive committee. So coming to the executive committee, the new president since this year is John Pryor, and the committee since this year is like this. So I am the chair, Zara, who joined us in this meeting. Hello, Zara. She was the previous chair. We have also Jose from Spain. We have Sofia from Portugal. We have a new member since this year, Humayun from United Kingdom. He's originally Pakistani. And also as a member of EXCOM is Ariane from Switzerland. So the certificate of fellowship of European Board of Nuclear Medicine gives you the right, and you should use the title of FEBNM if you succeed and pass MCQs and the oral exam. So the certificate looks like that. Okay, so actually what is important that the European Board Certificate in Nuclear Medicine proves the candidate's knowledge and ability in nuclear medicine to satisfy European standards. So we are focusing on European standards. Here I also have to note that actually we are using European guidelines. So answering your exam questions focus on European guidelines, not on American or any other your local guidelines. Also, the European quality recognition is optional, and it does not interfere with your national requirements for specialization. So this certificate does not prove you are a specialist in your own country. So you still have to pass your own country board. Okay, so what we need to get a certificate, first of all, you have to be a specialist in nuclear medicine, and it should be approved by the national health authorities. Also, you have to pass the full fellowship examination. This means MCQs and oral exam. So already you know, probably you have viewed already the preparation course which was sent to you about the MCQ. So we have this written part of 140 MCQ questions. This time, this year, it will be on site, but it will be not on paper as it is in this photo. It will be computer based. So you will have your computer and you will have a monitor in front of you and you will do it on computer. And also we will have during the Congress, well, actually before the Congress, the oral part. You will get 5 cases. So we will discuss how to do the oral exam. This year we have a huge number of candidates. So we have already booked 59 candidates for the MCQ part, and we have 75 candidates for the oral part. Actually, we have 20 people who who had already passed the written part and are coming only for the oral exam. We will have 8 examiners. This means we will have 4 peers and we will have 3 sessions for the oral exam. So it will be me, it will be Zara, Jose, Humayun, Savas from Cyprus, John Bascom from United Kingdom, Trond Boxrud from Norway, and Ariane. So those three, Savas, John, and Trond, are previous members of our committee, and we asked them to join this exam session because, as I mentioned before, we had a huge number of candidates this year. So what we are doing, we will be 2 examiners for each of you. This means 4 peers, and actually, as you see, we are coming from a lot of different countries. So we are covering a lot of different languages. So in case you need any support with the language, you have to contact the office and ask for language support. So we can help you with this. So as you see, there are a lot of different languages, and also some people are familiar with not only their mother tongue, but another language. So just request and we might be able to help you. Usually we were having like examiner pair, 1 female and 1 male. This time one of our ladies, Sophia, is not able to attend, so we will have only 3 ladies and 5 males. So some of you will get 2 male examiners. Again, if you have problem with this, just let us know and you will be shifted to the pair, which is sex balance. Okay, so going next, how it will happen. Well, I will return one more slide. So we will have a Friday morning session. During this Friday morning, those of you who are taking MCQs will be taking MCQs. Those of you who already passed MCQs will have the oral exam during this Friday morning session. Then all the others will take the exam during Friday afternoon or Saturday morning. Also, what I know from the office, some of you requested to have exam on Friday, so we will try to arrange that. Those of you who want to have exam on Friday will be able to have exam on Friday. So how it will go? Those of you who are coming to the session will be waiting in a waiting room 1 before the exam. Then we will invite you to the examination room. So it means 4 people at a time for 4 pairs of examiners. And after you had your exam, you will go to a waiting room number 2 and will wait until the last candidate of the session will go to the examination room. This means that you actually will not be communicating before the exam and people who already left. So it might be some inconvenience, but usually we have drinks and some snacks and you can chat in the room and it will not be so lonely to sit there and wait for a couple of hours. Okay, so what we are going to do in the oral exam. As I mentioned before, we will have 5 cases. A brief story of the patient will be provided. Then we will have discussion. And once again, remember that this is as your daily reporting session. You have to answer what you normally do in your department. If you, let's say, don't know how to report, or if you need another exam, or you need another scan, you just say that, okay, the scan is not enough, I will need another scan. So we will see if we have this one, we will provide it to you. Also, just act as you normally do. We planned to have one examination for about 45 minutes. Again, it is not as strict. For some people, it takes less. For some people, it might take longer, but approximately 45 minutes per one exam. So how to do? First of all, remember 5D. So detect, describe, think about, is this disease or artifact? Then what might be the diagnosis? And then differential diagnosis. One more important thing is clinical management or follow-up. In some cases, we will need this further clinical management or we will need a follow-up. So don't forget about these as well. So focus on physiological uptake, anatomy, barriers, artifacts, and we have the so-called MEM. So first of all, describe the major findings related to the clinical problem. Then we might have incidental findings and we might have minor findings. Usually, depending on the time it takes to have the exam, we skip this part if it is not important to the diagnosis or if it is not actually important in the clinical situation. Okay, so this is the first case I want you to present. Usually, again, during the exam, we will start with easier questions just to make you relax a little bit and not to be so stressed and focus on what is actually in front of you. So the first case, we have a female of 88 years old. She was diagnosed previously with Kaposi sarcoma of the skin, which is not AIDS related. And now she presented with the back pain. So we will ask you, what do you think? Normally we were doing this session live, so usually we ask participants, so what do you think? What probably a nuclear medicine procedure would you suggest? So if someone wants to tell me, just shout out. I will wait a minute. Someone?
Bone scan?
Yes, yes. So you get your bone scan. So now detect and describe, focusing on major findings, incidental findings, and minor findings. So what are your major findings?
The major findings is a thoracal vertebra lesion. And also lumbar spine. But
yes.
Yeah, and also another joint findings like in the knee and toe joint. This is the another findings.
So we will skip those minor findings now,
Yeah.
and I will ask, okay, so what you think? What is it? Or how you want to proceed?
It's osteodegenerative, I think.
How you want to proceed? You say this is degenerative and you're happy with that?
No, maybe we need another CT imaging, like maybe SPECT CT will be
you
better
ask for
to
SPECT CT,
identify
you get your SPECT CT.
This is the yeah, this is the end plate degenerative changes, and this is the benign lesions.
Yeah. So
Benign
as you
lesions.
see, this is very straightforward and very easy. This is how we will proceed during the exam. So maybe I will ask you once again, if you come back, do you see any lesions which are suspicious for metastasis?
Actually,
on the right thoracal wall, maybe we have like mild uptake in the soft tissue. I don't know if like the gender of the patient, but
Female. It was
Ah.
female. So what are those? Breasts.
they are breasts, yeah.
Yeah. So
We are
actually,
seeing multiple foci of increased uptake in the ribs on the left side posteriorly. They're contiguous and they could be fractures.
yeah. So my question again remains, do you see any suspicious lesions for metastasis?
in the little bit in the lumbar spine.
This one? No.
Yeah.
No. Okay, so I'm just trying to confuse you. Actually, don't be confused, because I think every one of you says there is no suspicious lesion. The only one was this one, and actually we had SPECT CT proving this is benign. Again, if you think about the first slide where we had Kaposi sarcoma of the skin and a female of 88 years old, how high is the possibility of having metastasis in the bones? Actually, probably very low. So don't be
Very
confused.
low. Yeah.
Don't be confused. Again, what I'm trying to say, this is everyday reporting. There is nothing, so much extreme. Just act as you normally act. Okay, second case. 46-year-old man addressed for recurrent pain of the sternoclavicular joints for 3 months. He is a hand walker, no relevant medical history, no trauma, no fever, no inflammatory parameters and so on. So what do you think? Again, any nuclear medicine procedure? Someone? Sternoclavicular joint.
Bone scan again?
Bone scan again. Here you go. Someone. Detect. Describe.
Nice.
There's increased
female lesion
Yeah.
and diffuse
Any ideas?
sternum lesion. Not lesion, just uptake. But maybe bone, maybe we need again for the SPECT imaging for
In
the
which
bone
area?
to see the any kind in the femur.
In a femur. Okay, you ask, you get. Here you are.
I think it's the chondroma, maybe chondroma.
This is the first mistake. You are correct, but this is the first mistake of having an exam. First of all, describe. Don't rush to the diagnosis in the first place, because if you are wrong, you will get, angry examiners on your face.
Okay. Lytic, sclerotic lesion in the CT and very intense MDP uptake and independent, and the age also very important, the age. and the localization also important. If so younger, and maybe we'll have to discuss about another kind of malignant tumor. But now it's I think it's sclerotic part and very intense uptake. And again, it's and no any kind of symptoms.
Okay, yeah, okay. But just pointing again, don't rush to the diagnosis in the first place. Also,
Yeah.
because we might ask you about differential diagnosis. This time I will not use, okay, I will ask you, is this benign? Is this malignant? What do you think? Well, it looks benign, you
Maybe
told me.
benign. Maybe
Yeah, it looks
benign.
benign. But I might ask, what might be the features for the malignant lesion? Well,
Nice
first of
question.
all, yeah, but first of all, if you look, actually, it is well defined. There is no disruption of the femoral cortical plate. So yeah,
Cortical, yeah. Okay.
yeah,
No invasion, no, and no any kind of symptoms.
yeah. Okay,
And no pain, no any, it's also so important. Yeah.
okay. Next case. So 74-year-old female, history of previous pulmonary embolism in 2020. Ongoing on the treatment, and she has pulmonary hypertension and dyspnea. So now, what do you think, and what kind of nuclear procedure would you think of?
VQ scan.
Okay, you ask, you get. Actually, it is not displaying pretty well. So this is the first slide, and this is the second one. So 3 first rows is one, and then the second. So this is VQ. Where is ventilation? Which one of those two is ventilation?
The above ones is ventilation.
Once again, this one?
Above slides.
Yes.
Yes.
Why?
That is because central deposition of radiopharmaceutical in the maybe trachea, slick.
Yep, good. So this is ventilation, this is perfusion. I understand this is not displayed pretty well. Are you able to describe it?
Yes, on the ventilation scan, there is central deposition of some radiopharmaceutical in the trachea and the proximal bronchi. During the perfusion scan, there is a defect, perfusion defect, which is looking like a bed-shaped defect in the left lower lobe.
This one?
Yes, this one. And this is more or less ventilation is preserved in this area if we compare the ventilation scan. But patient had history of previous event. So there are other areas also which are showing patchy uptake, like here also, that is coming to in the second row on the left hand side. We are able to see these defects, which is going in the left. The left lower lobe has looking like a large defect or multiple defects.
Okay.
So it's large segmental. It's looking like a size is big. It's maybe a segmental defect, and which is not matching with the where ventilation is preserved.
Okay. So what is your final conclusion?
It is looking like mismatched defect. So maybe embolus, new emboli is there, like new pulmonary embolus is there, and even on the right side, in the lower row, in the perfusion defect, we are able to see some decreased perfusion even on the right lower lobe also.
Yeah.
That is again not matching with the that is again mismatching with the ventilation, and it's again looking like a large segmental defect.
Okay, what is this? Those black dots?
Yeah, that is it's normally if it is preserved on the surface. So that means maybe it is not because of perfusion defect as such. We call it.
How you call it?
Sorry, I'm not remembering right now. But this is like it's preserved towards the surface, but it's not like looking like a wedge shape defect. That should be the wedge shape defect.
Okay, okay. So moving now to the next case. 63-year-old female smoker. So she has COPD. This is chronic obstructive pulmonary disease. She has a pulmonary nodule on her chest CT of 9 millimeters. And again, the same question. What you think now, and what will you do? Anyone?
Since this is a high-risk patient, we should go for an FDG PET CT scan.
Okay, you ask, you get.
FEBNM.
Okay, so can you see anything?
There is a small focus of increased FDG uptake in the right upper zone,
Mm-hmm.
which could
Anything
be
else?
a metabolically active nodule.
Okay.
This is the female.
Yes, this is the female.
Hmm.
Do you want any more images, anything?
Yeah, a CT scan maybe.
Cross-sectional images.
Fusion. CT.
Fusion. Okay, I've got fusion. What do you think now? Actually, it is written, yes. This is speculated tumor, right upper lobe with increased FDG uptake of moderate intensity.
Yeah,
In
maybe.
favor of neoplastic etiology.
Sorry?
Yeah, minor when
In favor of neoplastic etiology.
So what you will do? What you will suggest to your clinicians?
Needs biopsy.
Biopsy, yes. So actually what I think we will discuss that the lesion in the lungs might be benign, might be of indeterminate etiology, it might be malignant, but as we said before, it is speculated, it is of moderate intensity, and actually of which of those would you think it might be? Of course, we cannot tell without histology, but which one looks like the most probable?
It looks like a lesion in adenocarcinoma spectrum.
Yeah, yeah. Okay, so, and your suggestion to the clinician will be to make biopsy. Yep. Another question, which you would normally report. Are there any lymph nodes in the mediastinum?
There are some right hilar lymph nodes activity,
Here you
FDG
go.
uptake, yeah, and there's linear uptake in the esophagus, which looks like esophagitis.
Yeah.
And maybe some gastric physiological uptake.
Yeah. Okay. Actually,
No.
does this look suspicious to you? This. I don't have the scan in this area with CT actually, to be honest. Okay, probably it is dependent more on how to say, this is the lesion, very small, of 9 millimeters. How high is the probability of having metastasis already in the lymph nodes in mediastinum?
Very low.
very low. Also, I agree, there is some uptake, but for me, coming from the country with a high incidence of tuberculosis, any other, you know, how to say this?
Sarcoidosis maybe.
Yeah, so usually we do have this like slight uptake in the hilus, and we are not very suspicious about that.
And also patient have the esophagitis. Maybe for this reason, the patient have some reactive change lymph nodes in the mediastinum. Yeah.
But in this situation, we will have a discussion during the exam, what you think, why you think, and so on. So actually, there is
Should be.
no suspicious lymph nodes in the mediastinum, but I agree with you that we have to look at this, and we will discuss this during the exam. Okay, so this is okay, and we go to the other case. So this is 72-year-old male with fluctuating impairment in attention, executive dysfunction, level of cognition and alertness day-to-day, hour-to-hour, moderate memory impairment, symmetric motoric rigidity and bradykinesia, history of 2 occasions of visual hallucinations, and history of 3 episodes with confusion. Again, just looking at the diagnosis, what will be your idea?
Dementia,
Dementia, maybe you can
Lewy
already...
body dementia, maybe because of visual hallucinations.
Yes, correct. So you get the scan already with the arrows pointing at the areas of interest. Anyone, well, you will not get the arrows during the exam, but just for this course. So anyone willing to describe?
There's hypometabolism in the occipital region with posterior cingulate island sign, which is hot. So it goes in favor of Lewy body dementia.
Okay, so this is, yeah, so this is actually what we already heard. So do you want any additional scan to prove or to, you know, I don't know.
That scan?
That scan, okay. So you know already from the history and from the findings. So here is your DAT scan. Again, someone?
F-TOPA maybe.
Yeah, but DAT scan is more available and FDOPA is probably more expensive.
Yeah.
There is decreased uptake in both putamen, which is prominent in the left side, and maybe left caudate is also decreased activity.
Yeah, yeah.
So it looks like a typical Parkinsonian syndrome. Maybe.
Okay, so what will be your final conclusions of those 2 scans?
Parkinson's with dementia. Associated
Yeah.
dementia.
Just confirms the Lewy body dementia.
Yes, this is just Lewy body dementia. Okay, but again, we discuss it. We discuss the possibilities, but actually this is, yes, Lewy body dementia with actually, again, when we come back to the clinical signs, so this is this part, which is, how to say, what we see here. But this is Lewy body dementia. Okay, sometimes we do that
ఎట్లా
scan.
ప్రజెంట్ చేయాలనేది కూడా ఇయర్ ఫోన్స్
Sorry.
తెచ్చుకోవాలి.
Okay, so sometimes we do that scan, sometimes we don't. But sometimes we cannot show you, so we will ask you, let's say, okay, what next procedure you will do? If you say you will do that scan, we will ask you how the DAT scan will look in case of Lewy body dementia. This is just to show you again how it goes. Okay, so we are turning to the 6th example. As I said, during the exam, you will have only 5 cases. I showed you 2 bone scans. Normally, we show just one of a different type. And as you will see, we had bone scan, then we will have something like kidneys or or BQ scan or salivary gland, whatever, something like that. Then we will have maybe cardiac, maybe brain, maybe something like that. The fourth scan usually is PET-CT or some oncology scan, and the final one is a therapy scan. So this is the situation, case 6 in this case. So we have a 71-year-old man with a nodule, a big nodule in the right thyroid lobe, some lymph node, already big lymph node in the level 4. We had already performed ultrasound and FNA, and this is suspicious for differential thyroid carcinoma. So what is your attitude? What will you do?
Iodine scan, iodine 1:1.
Iodine 131 or
1:1. Oh,
1
1, 2, 3, whole body.
1, 2, 3. Why?
No, I would suggest for some blood test, TG level, and to find out the endocrine situation, and after that maybe to look through for the lymph nodes, maybe wash out from the lymph nodes.
Okay, in this situation, once again,
Maybe consider surgery.
yes, thank you, someone. Yes, consider surgery first of all.
Yeah.
So, yes, the surgery was done, and here are the findings. So what we've got now, we've got well-differentiated papillary carcinoma with lymph nodes, metastasis in the lymph nodes. So now, what is your attitude?
Radioactive iodine therapy.
Okay.
I will check again with ultrasound, and now with the blood tests, now the TG level, and if we see another lymph node metastasis left after the surgery.
Have you ever done ultrasound after the surgery?
Like where I came from, yeah, we always perform it after surgery before we decide iodine radio iodine therapy, actually.
Okay, so at what time after the surgery are you doing ultrasound?
One month later.
4 to 6 weeks would be optimal for also like to check the thyroglobulin levels, and also get away from the post-surgical like hematomas and also edema.
Yeah, this was actually my concern, because we don't do ultrasound after the surgery straight away, because it is just a mess in the neck and you cannot see anything properly and so on. But again, I will focus and point that actually if you look at the guidelines, so what the guidelines suggest, if you already have metastasis in the lymph nodes.
Yeah, give the thyroid I-131.
Yes.
Yes. If there is a metastatic focus in the lymph nodes already, we have to consider increasing the dose of the radioactive iodine 131.
Okay, so how much will you give?
Normally, the guidelines say it's about 100 to 150, but it depends on the clinical picture of your patient also.
Okay, when you say 100 something, then you should say that this is millicuries.
Yes.
Because
yes,
again, in Europe, we are operating in megabecquerel. So just, again, if you say in millicuries, just point it out during the exam.
Thank you so much, ma'am. Thank you.
Yeah, just to know, to say, because we are working in megabecquerels and it might be confusing.
Okay.
We know how to calculate, but just point it out. Okay, so yes, so normally after the therapy we have the scan. So what is your idea now?
Yeah. Very intense iodine uptakes in the thyroid lobe and lymph nodes as well.
Probably, yeah. Okay, so what will you do next?
It's a good sign of the iodine uptake. Maybe we'll try one more dose after follow-up.
When and how much?
Again, it will depend on the TG level and also the patient the scan.
Okay, so one more question. So when you will measure the TG level and when will you do the scan?
Like
We
in
usually do it like every
6
6
to
months.
12 months.
6 months.
Okay, anyone has another opinion? So, okay,
If patient has undergone lymph node resection, then we would like to see the extent of dissection, because as per the scan, this diagnostic scan, they are looking like good number of lymph nodes which are there if this is just a diagnostic 2 millicurie scan. So maybe we will discuss with the surgeon to see if it is possible to just take it out. If it is not possible, then we would like to go for, yes, so SPECT CT is showing definitely looking like some residual tissue as well as lymph nodes. So we will go for higher dose because already multiple lymph nodes are positive. So patient, as per the risk stratification, it's going towards the high risk for the structural disease recurrence. So we will go for 100 to 150 millicurie, and then after 6 months, we'll see the response by thyroglobulin, stimulated thyroglobulin, and radioiodine scan, repeated radioiodine scan.
Okay, so as you see, there are several options. Again, in some centers, people do like do the first therapy, then follow up, look at the thyroglobulin and so on, and probably give or give not the second dose. Other people will go directly to the second therapy. So those things will be discussed during the exam. It is not like I will tell you the correct answer. It will be a discussion. What will you do? How will you do this? Okay. So actually the patient went for the second therapy, and this is post-therapy scan. So any ideas now? Post-second therapy.
I would say it depends on the thyroglobulin level, because when we see a high thyroglobulin level, I would perform an FDG PET scan to see if we have some dedifferentiation going on.
Yeah, very good. Actually, I don't have it here, but yes, the FDG was positive. So again, I didn't want to make it a too complicated case, but as you see, this is a discussion and we will think what to do next. If we see that, if let's say we do PET CT and PET CT is negative, so what will you do next?
I mean,
We
it
usually
depends on
refer it to the oncologist.
thyroglobulin level.
Yeah, and follow up the patient. Okay, good. And okay, I will show you a very complicated case. You will not get such cases during the exam. The only thing showing it, I will just try to show you how it might happen if you have a case you have no clue at all, how we will handle the exam during this situation. So I'm showing you a very horrible case, but rule number one, be systematic. Don't panic. and don't rush to the diagnosis, which might be incorrect. So just read the scan step by step and try to be systematic. So this is a very horrible scan. Okay, no clue at all. Do you know what kind of scan is this?
So I would start describing with the physiological uptake we can see in the brain. So
Okay.
my first suggestion would be, we can see the brain, we can see the bladder, see something's going out via the kidneys. So perhaps we can see perhaps the heart, I'm not sure, perhaps it's just the tumor mediastinal, but I would suggest it's an FTG PET.
Yes.
And then I would go on and try to describe the other uptake. So we can see in the between the ribs, and we can see in the lower back of the neck. So probably this was an FTG uptake in brown fat tissue.
Yes.
And I would ask for some axial fusion images. Yes, exactly. And except from the physiological uptake, so I would just try to describe all the other foci where I can see the uptake. Yeah.
Actually, if you look, this all looks like brown fat.
Yeah.
But have you ever seen so much before?
To be honest, no. We try to give the patient some medication to see no brown fat tissue, especially in the lymphoma, in the young female lymphoma patients. But perhaps this is, I'm not sure. I'm not sure the whole body, perhaps it's a very young patient. Perhaps we can have some, perhaps we have some disease with some brown fat tissue involvement.
Okay, so what medication you give to decrease the uptake of brown fat?
So usually we try to do a combination with a beta blocker, and we call it doxytone, and we give also some tavor. So we try to do like the double mechanism to block it.
So
Yeah, so
we came suddenly to this area. You did it well. So beta blocker, something else. So what stimulates beta receptors?
You have to look for paragangliomas.
Yeah, I already showed you the images, but anyway, so yes, among all those, here is an additional lesion, which is very difficult to spot. But if you are systematic, and again, during the exam, if you don't notice it, we will probably point you this lesion. So what is this? Again, you rushed to the paraganglioma. Okay, so this is a tumor in the retroperitoneal space, and again, it is increased uptake. If you look at it, it is increased uptake compared to blood and muscle. So if we suspect this is paraganglioma, what can we do?
We have to do the dottate scan.
Okay, we can do this. So we also have a differential here as well. So we do FDOPA. We can do FDOPA, and then you will get your diagnosis. Of course, you can do something else. Okay, for example, other suggestion. What else you can do? Not only FDOPA. What else?
MIBG scan.
Yeah, might help. Or something else?
Dottate, as I.
Dottate might work. Something cheaper.
operated.
Yeah. some people, well, let's say like us, we have so-called tectratid, which is a somatostatin receptor analog, which is labeled with technetium. So again, whatever you have, you can try and see if you can get your diagnosis. So again, it is complex, it is difficult, but again, just showing you how to work it through. And believe me, we are not, trying to kill you during the exam. We are here to try to help you. In case you are lost or you are stuck or whatever, we will help and get it through. So I hope all of you will get certificates and we will have a nice photo with all of you after the exam. So now, do you have any additional questions or anything else to ask me? Anything? Someone? Organization, exam itself, whatever. Okay.
Perhaps I've got a question.
Okay.
The written exam question, are they mainly focused on clinical, or are there many questions for radiation protection, or where you really see are the main areas?
Okay, I will try to. Have you received the slides of MCQ's preparation session?
Yes.
Because there was a prep course on MCQs. I will try to open this one. And okay, okay, I will get to. So this is the, how to say, sections of questions. You will get them in sections. So as you see, those are clinical, those are physics, radio protection, quality control, radiobiology, radiopharmacy, radiochemistry, biostatistics, and bioethics. And you see how much questions in every section we will have. So not only clinical. Be aware of all other stuff we don't like, all of us.
But how many positive answer will be okay for the pass exam?
Usually we have, I think I removed it, we have at least more than 60%.
60%.
Yeah. Also, I will tell you that depending on how to say, if there are questions, because we analyze the results after the exam, if there are questions which nobody answered, so we remove them from the final counting. So again, you will not get your result directly after the exam. We will look through, we will analyze, and then we will get you results in a few hours. We will have a meeting between this MCQ part and the afternoon oral exam. And also you will get your time schedule, in which group you will have your exam, and you will come to the, depending on which slot you get, you will come on Friday afternoon or you will come on Saturday. But all the office people will be there and all of us will be there, so we will answer all your questions and all your concerns. So do you want me to go briefly through the MCQ part, or are you okay with your own viewing? Because this is the one actually you should have received, or you have any other questions about that?
Yes, please go with the MCQ exam parts.
So what was important, we have 5 options and there is only one correct. answer, there is no results as minus if you are not incorrect, because in British system, sometimes they do, if you got the wrong answer, then you get -1. So this is not like that. It is, you get correct answer, you get +1, and if it is incorrect answer, you get just 0, so nothing. Only one correct answer, you get some distractors. If it is an image in the screen, so you just enlarge the image to see. Also, when we are talking about oral exam, we go into the details. If you look at the image on your MCQ part, so this is very clear, very straightforward. Nothing, you know, very strange or so on. So just look at the image, enlarge the image, point the answer. If this was a bad image for the example. So this is just saying you how to manage your computer settings. So you get your big image, which you can look at, and then you can choose your answer. So some just points how to work through the questions. If you know the answer, you know the answer, so you go straight forward. You know, let's say all the other options are wrong, so this one might be correct. Okay, it's again good. If you don't know exactly, but you have a feeling, a good feeling, so again, go for it. Just from my experience, usually when your first impression is correct, when you try to think too long and you don't really know, and then you choose a wrong answer. So follow your feeling, it also works. Again, if you have no idea, you have to guess, or you are trying to choose the longest text or the first or whatever, this doesn't work. Also to say that now we prepare the exam that actually all the options are of the same length, so there is no longest option. So let's look at the first one. So this is already not like that. We will have the answer in the same line, so it will be the same length as all the others. So which one is correct? You definitely know it. Someone.
D.
B.
Letter
Yes, this
B.
is D actually. Yes, sorry. Again, this is a mistake. Yes, so this is the correct answer. You know it, you just go for it. Don't you know, look too long. So this is the first one, and just don't waste time on this. Okay, so which one is here?
Letter B.
B. Yeah, straightforward. Just go for it. Okay, if you have we don't have questions like that. We don't have so long answers because you spend a lot of time on that. So just take some time and maybe you can guess.
C1.
C. Yeah, C. Correct. So I just want to show you, I want to show you this one. So again, benign conditions, which typically show very high FTG uptake. So if you don't know exactly, you look at the possibilities. Seroma, will it have uptake? No. Lipoma? No. Hemangioma? No. Hamartoma?
No. No. Most commonly, no.
Yeah, but and so the only option we have left. So you can do it like that. Also, yeah, so this is hamartoma. So it might sometimes have a vague uptake, but well, normally not. So we actually took those out, and the only option left is this one. Also, if we just show, okay, maybe you saw, maybe you knew, maybe that is okay, but also if we just change to another, which is, I don't know what it is. Again, you just say all those options are wrong, and you are left with the only possible answer. So this is Schneider's papilloma with a very high SUV uptake. To be honest, I never heard about this before. This is the case from our previous chair Trond Boxrud. So actually, this is a very good example how to work through, because, well, this is rare. You cannot see it in a daily routine, but if you know that all the other answers are wrong, so probably this one is correct. So don't, worry during the exam if you don't know the exact answer. Again, another question. As I mentioned before, we won't have long answers. So normally it will be all of the same length approximately. But if you look at the question, what will you see? Anyone? A. Yes, this is the only one because yes, it improves overall survival by 4 months. So this is a correct one. Okay, therapy. As I said, the images will be very, very straightforward.
This is adenoma.
I see a few things. This one?
Functional adenoma.
Yeah.
Letter D.
Yes, yes, yes. Okay, what else? What else? Oh, the questions might be like that, so don't forget about the symmetry as well.
Yeah, it's the indium.
Yes, yes. Again, if you don't know exactly, you know that technetium doesn't give a high dose, for sure. FDG, it has a quick decay, so usually the dose is not so high as well. So the only one left is indium. Again, if you even don't know exactly, you can figure it out. Okay, so what else? This one? Again, very straightforward.
A.
A. Yeah. Yes. 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 Just think about normally, I think everyone saw how usually the injection is done, because technologist or whoever injects in your department, take the syringe, shake it a little bit, and then inject. So yes, it is a normal everyday procedure. Another one, it might be like that.
Candidate for surgery.
Yes, yes. Again, don't look, if we show only these images, this is only images which are important. Don't look, maybe I can see here something or whatever. If only those images, only those are, you have to focus on. So yes, C, candidate for surgery. Okay. This might look complicated, but again, probably you can have. No? Okay, I won't confuse you.
Every time confusing with this.
Yeah, so this one is every time confusing, but again, mentioning that actually we do have questions with biostatistics, bioethics, radiopharmacy, biodistribution. So if you had, how to say, long time ago, your studies in basics, so just go through again to be on a safe side. Okay, people, so good luck. I hope you all pass, as I said, and probably we will have our nice photo of all of us. And again, any more questions, remarks?
Thank you so much for your kind explanation. And any source you're suggesting for the quick look?
I think we have all the suggestions of the books on our web page, but also for those of you who are coming not from Europe, just quickly go through the guidelines, which are again printed on available on the EBNM website. So just go through to check the differences. What I can tell you now, so thyroid cancer management is more often, which is different. And we have two guidelines on benign and on malignant. So again, it might, how to say, it will not be mistake. We will go through this. We will ask, how are you doing? What you think and so on. But the differences are there. So go through those guidelines, at least briefly, to see what are they. Okay. And also, you know, all the new therapies which are now available, PSMA, well, iodine is, of course, is there, radium, yep, lutetium for neuroendocrine tumors. Okay. These are the areas which you might not do on your routine practice. So those you will have to look in the textbooks, or not in the textbooks, actually in the guidelines now, or new publications.
Okay.
Okay. Don't be confused. I remember when I had my exam and this prep session, and I was thinking, oh, Jesus, what I'm doing here. And it turned it was okay. So don't worry too much. You have your background. You are practicing nuclear medicine, so you are okay. Just be focused.
Okay.
Okay, people. Good luck and have a nice day.
Thank you very much.
Thanks so much.
Bye. See you.
Bye. See you.
Thank you.
Bye.
Thank you.
Bye. Thank you.
Thank you very much.
Welcome.